Welcome to this month's My Sexual Health webinar on trauma-informed care in sexual health with our special guest Lisa Grant-Stuart, a counselling psychologist, and she's also a My Sexual Health team member. We are happy that you are here. I'm Dr. Elna Rudolph, and I'm the clinical head of My Sexual Health. Lisa Grant-Stuart is a Bellito-based counselling psychologist with a special interest in trauma, health-related concerns, and complexities of everyday life. She works with both teens and adults, offering psychotherapy, life skills coaching, and neuro-based trauma therapies such as EMDR, EMI, eye movement integration, and BWRT. I don't know why I said EMDR. Maybe you must correct me there, Lisa. Is it
There
a
is an
place in my
EMDR
brain?
as well.
Is it different?
Yes, slightly different, but still using
Okay.
eye movements.
Okay. With years of clinical experience and a calm, compassionate approach, Lisa helps clients navigate issues ranging from anxiety and depression to sexual trauma, grief, and medical distress. She's also the creator of a CPD accredited course working with trauma during sexual health consultations designed to help healthcare providers offer a safer, more sensitive care. And you can access that course. Lisa will send you more information about that. I can really recommend it. It has changed the way that I practice. Lisa is passionate about making trauma-informed practice practical, accessible, and grounded in real-world clinical work. But welcome. It's such a pleasure for me to have you here, and it's long overdue that you and I have this conversation in this form.
So thank you so much.
Yeah, let's start with a poll to just see where everybody that's joining us here tonight. And the first poll says, in your experience, how often do trauma-related issues come up in sexual health consultations? Is it rarely? Is it sometimes, often, or almost every time? So you can talk about, if you're a healthcare provider, you can talk about your patient's trauma related issues, or if you are not a healthcare provider and you have had sexual health interactions, whether you've been to a gynecologist or whether you've raised any sexual health concern with a GP, has there been some trauma triggers for you there during those consultations? So I'm just going to give you a few more seconds to answer here. Rarely, sometimes, often, and almost every time. Yes. So you see here that half of participants say that they often see that trauma-related issues come up in sexual health consultations, and yeah, that is quite a lot. I think if you are sensitized to it, you will notice that it really comes up quite frequently, even in online consultations. When I'm talking to people about their blood test results, not trying to do a physical examination. We're not talking about sex or intimacy or anything. Someone is seeing me about their hormones. I can often see how there was actually a trauma trigger there. Okay, let's go to the next question. That is, what's your biggest challenge when working with trauma? Is it, I'm not always sure how to recognize it? I'm worrying about saying the wrong thing? I feel undertrained in how to respond, or I don't feel it's part of my role. So while people are answering that one, I can tell you, for me as a doctor, people who know that their main problem is around trauma do not consult me primarily, usually. If you have sexual pain, for instance, and it's actually due to a traumatic event in the past, I'm not the first stop typically. Or people come to see me knowing that there was actually trauma, but they're hoping that I will provide a medical solution. And I think that the other doctors on the call might relate with me there, where I'm here to provide medical solutions. And, so your head is focused towards making a diagnosis, writing up a treatment plan, going through that. And then here's the trauma response. And you're stuck between reaching your goals, which are actually, you think, predetermined by the patient's goal, because the patient wants to walk out of there with a script and a solution and but you can clearly see that there's this response, and this patient is booked only for half an hour, and then you've opened the can of worms, and it can be very difficult to deal with that in that situation. What I've now learned is that's the diagnosis. That in itself is already the diagnosis. The job is done. We've made the primary diagnosis has been made. I do not need much more after that. Yes, there might still be a diagnosis of provoked vestibulodynia or hypertonic pelvic floor or whatever, but such an important diagnosis actually to make, and both me and the patient need to acknowledge that that has happened, and then find a way to deal with it going forward. Okay, but let's hear what our participants have to say about it. Very few people said that. It looks like everybody feels like they know how to recognize it.
That's
And
good. It's a good place to start.
yeah, everybody feels that it is part of their role also. So that's great. And then about half of people are worried about saying the wrong thing and that they are undertrained to deal with it. And I think from the My Sexual Health team, that's kind of the message that we've been getting also. So we are so happy that you are here to at least tell us what's the right thing to say and give us some training on what to do. So thank you very much, Lisa.
Sure.
Do you have something that you want to start off with?
I mean, I really think, obviously, coming back to the first poll, the incidence of sexual trauma and sexual dysfunction is, the link is so clear. I'm often very surprised if I work with a sexual health patient who hasn't had trauma. So it's obviously way more underreported than we think. So it really is it's so relevant for my sexual health in terms of talking about trauma, what it does, what it's doing in the brain. So that I'm not surprised by. And what I'm hoping tonight is just, to really achieve is for people to be able to feel more confident when that patient is activated, because they do become activated. And I'm thrilled to hear that a lot of people can recognize activated patients. I call them, sort of activated, or, we use aroused in a different way in psychology, but, they're in a very, very high state of arousal. So, I'm thrilled that people can recognize that. But I'm hoping to equip everyone just also with a bit of their own framework around what they're seeing in the patient and in the patient's brain at that time. So that's kind of my goal tonight.
Okay, excellent. So let's kick off with the first question. Could you explain what trauma-informed care actually means in a sexual health setting?
Yes, sure. I mean, the trauma-informed care approach comes very much from the US. It's very big, and I think most of us practice trauma-informed care anyway. It's got 6 principles, that it's around compassion, recognizing someone's background, humility, support, follow-up. But for the two that I want to talk to tonight is resiliency, so fostering resiliency in your patient, and then also understanding trauma and stress in your patients, a lot better. So how I always start with a patient is really helping them to understand that their trauma response is out of their control. It is their brain being activated in that moment, and B, that when the original trauma happened, all their brain did was take in too much information and actually hold on to that to try keep them safe. So what we know in terms of neuroscience is that trauma doesn't go away. It actually doesn't get processed through talk therapy. I'm going to be hated. A lot of my colleagues are going to hate me for this statement, but I'll explain why. And we know that when it's experienced or, as a flashback, it is very, very vivid. So it takes a person right back there into that moment. And it's really out of their control. We can, when we talk about trauma, we talk about, the fact that your actual thinking centers are flooded. And I'm sure you've seen it in patients who are activated. it's like they lose their rational thought. And there is a reason for that, and that's simply because, you know, their brain is absolutely flooded, their frontal lobes have shut down, and they've gone straight into the, you know, the good old responses of either fight, flight, or freeze. So the freeze patients are the, you know, the ones that really just keep quiet and kind of go within themselves. You know, the flee ones are about to go out the door. And then, you know, in terms of the fight ones, they're usually the patients that get quite defensive and almost quite often angry, you know, with your diagnoses. So,
and what about the fawn? Because, sorry that I interrupt you,
yes,
because I know
the fawn. Oh, yes.
fawn
So,
yeah.
yes, I'm glad you mentioned that, because people always get the freeze and the fawn confused. So the fawn is actually a people-pleasing response.
Yes.
So those are the patients that are experiencing trauma, but they try and make out as if they're fine. When Stephen Porges originally made his model of, you know, sort of fight, flight, freeze, and then the place where we want to be is social engagement, he didn't include the fawn. So that's something that's sort of a little bit new. Not many people are sort of buying into it just yet in terms of, you know, sort of neuroscience, but absolutely. Yeah. And you know, just while I'm on the topic, sorry to interrupt. I'm going to bring my brain in just so that people. So this is what I literally. Sorry, I'm going to see you. This is literally how I explain it to patients, that this is your fight or flight center, and what happens is we always try to think our way out of the trauma, but when this is too active, our memory systems, which are here, good old hippocampus, actually become affected as well. And that's also the reason why a trauma memory is given so much space in our brain. I often say to people, you can remember the trauma as vividly, you know, with all the smells, the details, the everything, but you can't even remember what you had for breakfast 2 days ago. So that's what's really relevant, you know, to the patient around. They feel very guilty about having these triggers, about having these responses, about not being able to control them, not being able to explain to their partner why they are behaving in this way. So, yeah, so that's just a little bit around how to enter, you know, with that knowledge, you know, with your patient, and even just being able to explain it to them is hugely relieving. Because then they know it's not, you know, they know it's nothing that they're doing. So.
I've got so many scenarios going through my brain.
I'm sure you do.
About patients and personal stuff and family and everything, you know. So, what I want to ask you is, for the kind of work that you do, does it need to be a big trauma? You know, do every day, what is enough trauma to take up that big space of memory in your brain?
Absolutely. So we do know that people will experience things completely differently. You know, what is a trauma for me is not a trauma for someone else. And it is dependent also on what we call trauma load. So also research from America, something called the ACEs. I don't know if anyone's familiar with it, adverse childhood events. So generally, the more ACEs,
the ones that you can remember now,
yes, so it's neglect, abuse, domestic violence, whether or not incarceration of a family member, being exposed to witnessing domestic violence, witnessing a crime, you know. So there's and if you sit with a checklist, what we know is that people with more ACEs will go on. Oh, there we go. There's the ACEs. Thanks, Lisa. People will go on then to develop more severe responses later. However, trauma is subjective. So I have patients who have been through the most ridiculous amounts. I mean, their ACEs scores are off the charts, and yet they are highly functional. You know, they hit one or two challenges in life, and it's almost as if that trauma load tips. And then I have other patients who have had a relatively, you know, easy upbringing, good support, but have experienced something, for example, like birth trauma. So that's very common, you know, and it's such a shocking, such a raw experience that it's tipped them into post-traumatic stress sort of presentation. So it is totally subjective, and I always say to people, you cannot compare.
Okay. Yeah, it's not like if you've experienced this is going to happen, or
Yes.
oh, this is happening to you, but you only experienced that.
Yeah, but but it can't be that bad. You know,
Yes.
we were one of the questions for later is what not to say to patients, and that's definitely it. You know, like, oh, but
Absolutely.
that was only,
Yeah.
that was
Yes,
only a
yes.
miscarriage, or that was only,
Yes.
and yeah, so that is a definite no-no.
Okay. Why is it so important for healthcare providers to understand the neuroscience behind trauma?
Yeah, I think first of all, you can, when your patient is activated, you can ground yourself as a
Okay.
practitioner. You can say, this is somebody who's had trauma activated. I am not re-traumatizing them. So that's a big concern with practitioners. They see this response and they think, I'm doing damage to this person. So that is, I think that's really important. Just the other thing is just, really, just for as a practitioner to go in with the understanding that everyone is walking into your office with a different brain, and a different nervous system. So one of my most amazing mentors, Minnie Loebscher, has always taught me to assess what kind of nervous system is coming into your office at that time. So are they activated? Are they in freeze? Are they ready for treatment? You spoke earlier about, sort of being on a schedule, and suddenly a patient is not going along with your schedule, And one of the things for me about trauma-informed care is also flexibility. So we've got to, I often do it, somebody comes in for treatment, I can see they're not in the right mind frame. They've just, the child's sick, they've been up all night. And I just say, sorry, we're not doing that today. We'll do something else, but we'll reschedule. So, so I think one of the things for practitioners is really just to hold that flexibility in mind, and really just assess at that moment, where is this patient at? Why are they in my office? What is their reasoning for seeking help? Are they going to feel relieved? Are they going to feel disappointed? So that's one of the that's
Okay.
one of the things.
I just want to go back to you saying that the person is having a response and you are not causing it. But
Yes.
if you are a healthcare provider and you are like trying to do a pap smear, for instance, and the person
Yes.
is having a response,
Mm-hmm.
how do you know whether it's okay to continue with what is happening here now, and when, because I have seen many people, and I'm sure you've also seen people who have been
Yes.
traumatized by their healthcare
Absolutely.
providers.
Absolutely.
How do we know?
Yeah. So in that moment, I mean, this is where I, as a anyone watching this can hopefully do a little mini explanation around what I'm saying, that this is
Okay.
just an old memory that has been activated. I have done something that has sort of almost played with your framework of that trauma.
Okay.
I'll never forget, Candice Langford said she always had a patient who came, as soon as she came around the side of the one bed, she would,
Yeah.
she would become activated. So through our discussions, she could then share that information with the patient, and also just reassure them, say, are you okay to continue? I use the idea of, this is an old memory. This is, this has got nothing to do with what's happening now. And then anything related to grounding. So water is a great one. Would you like a sip of water? Can I start with a safer touch, for example? So you can desensitize the patient slightly. Yeah, and as I said, grounding. I think I was going to take everyone through a grounding exercise. Some people do breathing, box breathing. There's one with sort of 5 fingers. most people
Okay.
use that.
Let's do a grounding exercise. So I'm just going to
Okay.
create a picture. Going to create a picture. Somebody
Yes.
comes in. This is a picture
Yes.
that I've seen many times. They arrive 10 minutes late to the consultation.
Yeah.
They've had sexual pain for 5 years, unable to penetrate at all. And they thought that they were going to have the Botox during this first consultation that they were 10 minutes late for. But I
Oh,
must take a pap smear now. Okay. So you can say already arriving quite activated.
yes.
Then when they are undressed and I am just touching very gently to open up the labia, they
Yes.
are going like this, go like retrieving up the bed. Okay, so this is where we are at. What do you do
Yes.
now?
Yeah. So, I mean, at this point, I might want to say, should we be doing this today? Do you want me to continue? So that's also around the informed consent. Give water, but then in terms of the 5 senses grounding, I absolutely love it. So if you're online at the moment, if you can just kind of do it with me, and it doesn't need to be all 5. You can use your own version of it, but as you sit in the space at the moment, wherever you are, okay, just notice 5 things in the space around you.
I'm going to go offline while you do this exercise. I'll switch on my camera when we're done again.
Perfect. So just anything you can see, anything in your space. Okay, good. So once you've done that, just 4 things that you can feel. So at the moment, I can feel my shirt, I can feel my hair, I can feel the chair. And 3 things you can hear. And 2 things that you can smell. Sometimes this is a hard one. And then lastly, 1 thing that you can taste. Yeah, and when everyone's ready, just, slowly come back.
Oh, you're going to have a much calmer presenter now. You should have done that with me when I arrived.
I wish I'd known.
Yeah, it's wonderful. It's amazing. It's amazing what that does. It's so simple.
Very simple.
So you would, let's say now she's up on the bed here now.
Yes.
So I get up, I stop what I'm doing. I ask
Yes.
her, is she okay? Can I get her a glass of water? Do I go straight?
Yes.
Do I go straight for that?
Yeah, I must admit, for me, I'd always do water first. And then if I can see that that's not helping and they still, then I'll go into almost like a simpler version, which is, can you feel the bed underneath you? Okay. And just whatever's happening here is old. This is just your brain, protecting you from something else that happened. But that's not happening today. So what you're doing is you bringing the patient back, because trauma collapses time. It is that immediate, they straight back in that moment. And then if they really are struggling, then I would use the proper grounding with them. And then really if they are, if that's not working, I would then have conversations around, look, I think, I think therapy would be a good option. I really think exactly what you said earlier. I think we actually already have our initial treatment plan. And it's not going to be Botox today. And it's not going to be, it's not going to be a pelvic exam. I mean, I'm sure, talking to a lot of the pelvic health physios, most of them will not, won't do internals for many sessions until their patients really, really trust them and feel safe. So
Yeah.
that's that idea of we have to meet the patient where they're at with their trauma load and where their brain is at that point. The other thing, which is never really a good go-to, but medication. I've often said to people, we need to bring your level of arousal down, and we're going to fight against, your brain constantly moving between fight or flight, the entire time. So we do then need to discuss medication, because we need to aim for success, and not for your experience of treatment to constantly be, so stressful. So
Yes.
yeah.
So are you talking about, let's say, somebody taking an Urbanol before they have a pap smear? That's
Absolutely.
an option. Okay.
Absolutely.
But are you also talking about using medication while you do your therapy?
So generally, for my treatment, or the neurotherapies, we actually try not to use Urbanol. They might need a longer term antidepressant before we can start working. The one thing about a neurotherapy, obviously I'm the biggest fan, but it's heavy work.
Yeah.
It's fast, and it's quick, and you push the brain, but you also know the brain can do it. So that's the other thing. We try not to use it, us personally as therapists, but I've often said to people before they go for pelvic health, anything, examinations, please, if you do have an Urbanol, if you do have what's the other one to relax muscles, I've gone absolutely blank.
But we use microcam or
Yes,
Norflex,
microcam.
something like that.
Yes,
Okay.
absolutely. So to make the experience of the physical stuff more bearable.
Okay. Just to prevent you going into a fight and flight during. So what
Absolutely.
about people, because I so often, today I had a consultation with somebody that explained that when their partner starts to touch them, they go into a fight and flight, and that then so they become neurologically aroused, but that prevents them from becoming sexually aroused.
Completely.
There's no vaginal lubrication.
No.
Yeah.
Mm-mm.
So would you, well, what would you advise in a situation like that? Let me rather put it like that.
I think maybe in my typical approach, I tend to use humor. So I always say to my sexual health patients, I'll say to them, remember, when your brain is activated in that moment, you literally imagine the threat is right there. So although it's not in the room, it's not happening at that moment, the threat is there. And I always say, do you ever see animals mating in the wild when there's a predator, right there that they can see?
Yeah.
That's how vivid the trauma actually is in that moment. So, and then they, because the state that we need to be in for intimacy is social engagement, which is calm, relaxed, safe, feeling free, feeling expressive. But you cannot, the brain is very, very simple. You cannot be in social engagement and fight or flight or freeze. It picks one. That's it. So as I said, I tend to use a bit of an obvious one. I'm like, well, of
Yeah.
course, what your brain is experiencing in that moment is very real to you. It's the same as a predator in the bush, and now you're supposed to relax and feel safe. So I think that that kind of explanation is quite helpful, because
Yeah.
I have so many patients saying to me, but I know this person is my husband. I feel safe. It's not what happened previously. And I say it doesn't matter. It's got nothing to do with what your poor husband is doing or what your poor wife is doing. It's got to do with the fact that it's activated that unresolved trauma that hasn't been processed, and has been given a much larger portion in your brain to keep you safe.
Okay. So if somebody's here tonight and they're experiencing that their fight and flight is triggered when
Yes.
there's a safe situation, and you know, well, like what you experience now, they know that they can be safe with their partner, but their fight and flight is triggered. Would
Yeah.
a grounding exercise with themselves, the 5 4 3 2 1 thing, like in the bedroom, it's
Very much
about
so.
starting to happen, will it help you
Absolutely.
take yourself through a grounding exercise
Yes,
like that?
very, very much so.
Okay.
Very much so. So what you're trying to do there is engage, because fight or flight response, remembers the center of your brain. So the senses exercise actually brings, the rest of your brain into play.
Mm.
The other strange thing, believe it or not, is distraction. As soon as we can engage the frontal lobes in that moment, so I'm like, well, watch a movie, beforehand, and
Yes.
then do something. So you just need something to be able to break that response if it's still activated. Obviously, me being me, I would want to get rid of it altogether, and that's more
Yeah.
where therapy comes in.
Yes, yes, yes. Yeah.
I have a philosophy of, like, don't live with it if you don't need to. Um,
Absolutely.
but the grounding, very, very much so. And also the desensitizing. So take it slow. I mean, it's all the things that we taught, at my sexual health is, do things in stages, so that the brain learns to sort of titrate that response of, I'm safe here, and I can withstand this activation.
Okay. Okay. Now we're going back to my patient. I
Yes.
offered her some water. We took her through the grounding experience. We realized not pap smear Botox today. Off to Lisa. What would you do with her now if she arrives in your practice? How does it actually work?
Yes. Okay. Great. So, I'll try. Again, keep it fairly simple. But I practice. I mean, there are many types of neurotherapies, and actually, BWRT isn't considered a neurotherapy, although it does use the mechanism of the brain. So, what I would do is I would. Yeah, so sorry, I meant to mention I do eye movement integration therapy, BWRT. Some people do EMDR, which is what you mentioned earlier. Brain spotting is one, and then somatic experiencing. So Peter Levine's somatic experiencing. So I would then assess the patient in terms of major traumas in their life, what they think could be activated in that moment. Sometimes there isn't a memory of it, but we do find it along the way. I'll just briefly explain EMI and BWRT and a little bit of SE, just so people know what I'm talking about. But so eye movement integration therapy actually literally takes the fragmented memories, that people have, because that's the other problem, is that when we experience trauma, it's almost like the memories become fragmented, but they become bigger. And what eye movement therapy is, and it's always the most bizarre thing to explain to people, and I love the look on people's faces initially when I explain it, but there is a tiny little structure in our brain, right in our limbic system, the fight or flight center, that controls eye movement. So, and it's linked directly to memory. So how eye movement therapy works is we actually take the eyes through a series of guided movements, because what it does is it actually facilitates recall of a particular trauma. It integrates all the different senses, smells, textures. Smell is a very, very big one that always catches people off guard. They remember the smell of that room, or the smell of the hospital bed, or body sensations. So all of those, what EMI does is it actually taps into all of the sensory experiences. It desensitizes them, and what actually happens is that the brain is then able to get a bigger picture of what happened. And brains are amazing. Once it's got the big picture, it actually moves that material, I call it material, trauma material, from your immediate memory, which is your trigger zone, and it can put it back into long-term memory. So that's eye movement therapy. And it really is just, it's just using the mechanism of the brain to heal itself. I always say it's really nothing fancy, although obviously I love it. And then BWRT works further back in the brain at the reflex center, and it's absolutely brilliant for neutralizing memories and responses. So, for example, with a sexual health patient, I'll often use a combination of these two. I love BWRT, either for dealing with small chunks of trauma, or you can actually what we call scaffold a different response. So BWRT works further back, almost before that information hits the front, and we suddenly are going, this is my husband, it's okay, things are okay. It actually catches the response much further back in the brain. And we can insert an alternative response of like, I'm actually fine, I'm safe. So exceptionally powerful therapy devised by Terence Watts. And then somatic experiencing. So this is my, I always say this is my new child. So I've got EMI and BWRT on my older children, and somatic experiencing is my newer one. And obviously that's just hugely based on Peter Levine's amazing work with how trauma is stored in the body, how we can actually, work with different somatic practices, different movements to actually evoke responses and create different memories. So yeah, so I would always sort of assess and see like what I would use in various ways, put it that way.
So let's say this particular patient had lots of bladder problems when she was a small child. She needed to have quite a few operations, and it involved things down there. So you think that's the most likely association why she reacted like that in my practice.
Yeah.
I want to ask you, if you did a somatic therapy, what would that look like? What would happen in the 3 hours that she spent with you?
Yeah, I mean, it's, as I said, it's hard to explain. Funny enough, I'd probably, for that case, I would probably use EMI, just because there's a whole lot of there's a theme that I can work with. So so then, as oddly as it sounds, we'd sit in my office, we'd choose a set of words, and then I would literally guide her eyes through a whole lot of movements. And she would say, okay, so now I'm thinking of, that one doctor, or now I remember that one procedure. And, obviously, patients become, very anxious, very activated, very, sweaty. Sometimes they even remember stuff which is wonderful. So this is where the resiliency comes in. People start to go, well, hold on a minute. In all of this, I'd actually forgotten, that my mom was so wonderful, and that I actually had really good support. And because the brain has just chunked it into this load. So typically an eye movement session is about 2 hours. It's long, because we're just taking the brain through a series of exercises. If anyone wants to look on my course, you can actually see the different eye movements that we would use. Generally, by the end of the session, the person's tired. They suddenly are hungry, so we know we're back in social engagement, and we're coming out of the stress response. If I was to use something like BWRT, we would actually break down, we'd find like the worst of one of the incidences and then work with that. BWRT is quick. Generally, we can work with one incident or one trauma in probably about 20 minutes. So it's very quick. So I would really just assess, and then a somatic experiencing, sort of session looks very different. You sort of sit and you just really connect with different feelings. You see what the body presents with, and you constantly are feeding that back into the nervous system. So Peter Levine's work is about balancing, almost the good and the bad in the nervous system. So you can't just treat the good, because then actually you get what's called a counter vortex, which actually, will flip the patient back into the bad. So it's almost about restoring the balance of the nervous system. So I'm sorry, it's a bit of a long explanation, but and there are fantastic authors, and please read up as much as possible if anyone is interested.
So the somatic does not necessarily involve movement. It refers to looking
Yeah.
into the body for the
Yes.
feedback, but it's not
Absolutely.
necessarily a movement.
Yes, yes, absolutely. So it could just be a feeling, but you very much are tracking the body of the patient. And actually, now that I mention it, we have got some other my sexual health team members who are currently on a course with me for somatic experiencing. So somatic experiencing is a course that you can do if you're not a psychologist. So it's wonderful because we get lots of physios, involved. We get lots of other practitioners involved. Whereas BWRT and EMI are sort of, especially in this country, are governed by the HPCSA. So it's generally social workers or registered counselors or psychologists who can do those modalities. So if anyone is interested in the body work and in regulating the nervous system as a whole, then somatic experiencing is actually definitely the way to go.
Okay. Interesting. Yeah, I'm always worried I want to send my patients to the best of the best, So I'm always a little bit worried about sending to people who do not have a very solid foundation as a primary qualification.
Yes,
I think that
yes,
is it's a good place to start.
yes,
But it is so beautiful what we've seen, and that's the reason why we build the team the way that we do, because each one of us bring primary knowledge to the table, but we so benefit from the knowledge and the skills, the soft skills that we learn from our colleagues to be able to render a better service to our patients.
Absolutely, absolutely. Yeah. So I was very excited to actually meet, some people in real life for a change, especially being out here in Belito. We never see the team. So
yes. Yeah. Okay, so just we will have to do some quick fire now because the time is almost
Perfect.
up, and I still have a
No,
lot
that's
of
great.
questions.
I'm almost done anyway, so I'm good. Yeah.
What are the common signs or behaviors that might indicate that the patient is carrying unresolved trauma that we can look out for?
Yes. So also look at the body, flushing, hot, sweaty hands, rubbing their hands on their, on their pants because they, so those are sort of more in the fight or flight response. It's generally pupil dilation. Also, whenever somebody requests a lot of water in my office, I know that their mouth is going dry. So it's all of these symptoms. That's why we drink water during presentations. Or the typical freeze response is your very depressed patient. So this is somebody who actually has been through fight or flight. These are the ones that we worry about the most, who've actually been through fight or flight, and they're in a state of collapse. They are very depressed, very despondent, and have literally gone within themselves. Talking about the fawn response, it's the pleaser patient. It's the patient that always wants to get everything right. Yes, and tickle the boxes. That would be the indication. Obviously, when we're dealing with severe PTSD, it's flashbacks, nightmares, night terrors, lots of excessive alcohol use. Patients who startle, if you open the door, or if you again approach them in any other, from a different direction. So there we're dealing with with somebody who has full-blown PTSD.
And then I think if we can explain to patients that what you have explained to us tonight, and that it is actually possible, if you have the right treatment modality, to
Absolutely.
deal with this trauma during a short period. Everybody is cash strapped and cannot think that they must talk for 10 sessions and then still not have it resolved. So I think offering them a modality where there's a good chance, and then an experienced therapist will know whether they can offer a modality like that, or whether they still need to do more preparation and so forth. It's not like they walk into the first, or do they sometimes walk into the first session and you can do it all in that one session, or how does that?
I'd still need a good, probably 2 intakes, but thereafter, In South Africa, we get normally about 15 sessions if patients qualify for PMBs, but so 15 sessions of psychotherapy. And normally in a sexual case, that or actually even a normal trauma case, we don't even make it through the 15. So I think talk therapy for me, and obviously that was how I was originally trained, is so wonderful for understanding yourself and insight and family history. But I always say, not when it comes to trauma. We're dealing with the wrong part of the brain. You're engaging your frontal lobes too much, for other things. For trauma, neurotherapies are it just makes sense, actually.
Okay, cool. And what can we wait, now I must see which one. The language that we can use, and let's talk about the language as well as the environment that we who are not counselors, we're physios, we're doctors, or some people are just teachers at schools, or they engage with people at churches or wherever. What can we do to create a better environment and be more trauma informed and sensitive?
Absolutely. I mean, I think it's again, it's more about the not, what not to say. Like, stop doing that. You can't feel this. We have a saying in my family that is, feel the fear and do it anyway. So it's more just about recognizing, this is scary. I can see that this is really hard for you. So the acknowledgement, the reassurance, going in with your own nervous system, understanding that the patient is going to be okay through this, I think is very helpful. So, it's, the reassuring language, drop your voice, take it slow, anything you need, how can I help? Keep your own level of excitement down, so that you don't further escalate, the patient. So for me, it's not even in the language; it's in the being, and it's in the acceptance that this is what this person's going through. This is what is happening in their brain at this moment, and we can change that. I think that's the lovely thing about being in neurotherapy is we can see what we can do. Whereas when I didn't have this, when I was a young, fresh intern, I told myself that the last work I'd ever go into is trauma work, because you felt so unprepared. It was terrifying. So I think for me, it's not really about the languages. It's just about, it's about what we can bring in terms of safety and reassurance.
Okay, sure. Because I can really see how, as doctors, we had very little training in this, and you see someone is that triggered, it does trigger you, and then you being triggered is obviously not helping the patient. And I can really, I have to stand here on behalf of so many patients that have shared their stories with me about how traumatized they've been in healthcare setups, how they have experienced medical gaslighting, and how they have experienced doctors just think that they are doing the patient a favor by pushing through when the patient is clearly not giving enthusiastic, informed consent, when the patient has actually gone into a complete freeze, and which means they are no longer giving ongoing consent to what's happening.
100%, yes.
You need to stop.
That is such a good point, because actually neurophysically in that moment their frontal lobes are not working, so then what are they consenting to? So
and you have to be careful, because if you are acting without consent, then it's completely unethical for us to be doing that. So it's not conversations that we had when I was standing around patients' beds when I was a student more than 20 years ago now. Hopefully it's changed. I think that young people are more psychologized anyway as they go through school now, and hopefully the newer generation therapists and doctors and nurses and physiotherapists, everybody is more trauma informed, but we have to pay attention to it. And I liked what you said. So what did you say? It is scary, but you do it anyway. Or what did you say?
Oh, feel the fear, but do it anyway. You know,
Okay.
so
But
this idea of don't be scared is
yeah.
ridiculous, because of course you're scared.
Okay.
But yeah, we have a joke in our house whenever any of us do anything brave. It's feel the fear
Yes.
and do it anyway.
But do it anyway.
So
Yes. Okay.
yeah.
Well, there's a fine line between, it doesn't mean do something that you don't want to do. This is something that you want to do, but you are you are, I guess that's the resiliency that you spoke about. So maybe you
Mm,
said in the beginning you want to bring that drive that point home. So let's
mm.
just talk about resiliency to end this off.
Yeah, Shem. Well, we've got one question from Rebecca. I don't know if you want me to answer that, and then
Yeah, you can go
and
ahead.
then hop
Yes.
on to resiliency. So I'll try to combine the two. I'm keeping an eye
Hmm.
on our time. So, yeah, Rebecca. So often what will happen is that you'll immediately see a change in the person's breathing. Their body will relax. You know, and again, communicate with them. How are you doing? How's this feeling? I get scores. So I'm like, okay, so if you were at a 10 out of 10 5 minutes ago, how are you feeling now? And they might say, oh, okay, so I'm about a 5. Okay, cool. So can we proceed? Is this comfortable for you? Tell me when you need me to stop. So generally, scanning their body, watching their physiology, checking for feedback, getting ratings is really helpful. Shame, I hope that answers your question. Okay, you're welcome. The other thing is, last thing about resiliency is sometimes when a patient is so activated, I'll quickly say to them, tell me something good that happened to you today. Tell me about something hard that you've overcome. So what you're immediately doing is flipping the brain into a mode of I can do this. So
Hmm.
that's the
Okay.
idea of fostering support, fostering resiliency. Tell me something that made you smile today.
Okay.
So there you bringing in, and then you can just focus a little bit on that feeling. How does that feel for you now? And
Okay.
where do you feel that?
Oh, nice.
So yeah, so it's actually a somatic experiencing technique where you bringing in a positive feeling to sort of titrate a negative. So yeah,
Okay.
sorry.
And I like that method because we can also be quite patronizing in saying, no, but you're so strong because I could, and so you impose the positive feelings or your
Exactly.
evaluation of their positivity on them. But what you're
Yes.
saying is let them go inside and
Mm.
find the positive.
Absolutely, because everyone's got one. Doesn't matter how depressed or traumatized they are, everyone's got it. So
Okay. So just can you please just repeat like one or two questions that you could ask if you want to evoke that in a patient?
yes, I always love the tell me something recently that you've done that's hard.
Okay.
Can you tell me a bit about that? So then they can elaborate, or tell me about a trauma that you've survived, or the simple one, look outside. What do you see that catches your eye that's beautiful? Something that made you smile today. What was something good that happened to you this week? So those are both grounding, but also resiliency. So in my intake, I always ask, tell me about some of the best things that have happened in your life. And then, because there I always keep an eye out for what those were. Tell me about a time that you felt really proud of yourself in overcoming something. So I always keep those in the back of my mind. If I need to bring them in a session, I'll just say, well, just remind me about that time that you did X, Y, and Z. And they'll be like, oh yeah. So that's also about that really, yeah, really bringing out the resiliency in someone.
Thanks. I'm going to remember that because people sit and they tell me 20 things that's bad with their health. But I think if we talk about things that are good and just like
Mhm.
uh, having legs that work or a
Mhm.
brain that works, those there are so many good things going. I think
Yes.
it is well, gratitude practice is, we know what the advantage of that is. But I like
Yes.
to just like have that little tag
Yeah.
of positivity that comes in right from the
Yes.
start.
And it's
It makes
patient led as well. It's not a saying. It comes from the patient, which is very important.
Yes. Yeah, they are actually speaking life into themselves. I like that very much. Okay.
Thank you, Elna.
Thank you, Lisa, for tonight and for sharing with us so calmly. And thank you for what you're doing for our patients. That is just, it is remarkable. It is
Well, likewise, I
so
really appreciate
beautiful.
it. Thank you.
So beautiful to see when healing really happens and people's lives change dramatically. We live in a world that is so drenched in trauma. It is wonderful to know that there are actually scientific evidence-based solutions that can change people's lives. So thank you for bringing that to the world so professionally and for sharing your knowledge here tonight. I really
It's my
appreciate it.
absolute pleasure. Thank you, Elna. Have a wonderful evening, everyone.
Thank you so much for joining us and sharing this space with us. I appreciate it. Good night.